Bonjour à toutes et tous, merci beaucoup pour l'invitation, c'est un plaisir d'être ici. I think I will switch to English because I don't want to impose my accent from Neuchâtel to the translator. And a lot of technical terms are a bit tricky to say in French, so it's a great pleasure to be here, as I said, and I'm really grateful that Richard and Alex are there. They are, advising us on this project, and it's a lot of inspiration that we got from them, so a lot of credits to Richard in particular for allowing us to try to apply his methods in Switzerland. So basically what I'm going to do is present this ongoing project. So you understand that's an ongoing project. We're trying to derive results now from the data. And we try to do as best as we can with the data that we have in Switzerland. So I will show you a few results at the end. And before talking about the project itself, I wanted to go back to one of Richard's picture, which is this one, the beam. And for two reasons. First of all, as Richard said, we're always focusing on averages. Health policymakers, health policy academics, or health economists, as I am, we often focus on the mean, the average. And I think we should go further, look at heterogeneity in impact of policies in different subgroups of the population. The second reason is that it reminded me of a very nice album from Pink Floyd, Dark Side of the Moon. That's the cover of the album. And one of the songs that is very well known in this album is called Money. And I just wanted to raise this, I call it Dark Side of Switzerland, but I think it's very important to understand for people that are not from Switzerland, that in fact only about 30% of our healthcare spending is financed by income-related contributions. And more than 2/3 of our health expenditures are financed without any relation to income. So premiums, deductibles, cost sharing, and direct contributions from households. So what's the take of Switzerland as a very high quality system, which is true, but the potential financial barriers that people can face in the country is very important to take into account to understand how equity related issues could emerge from that. So let's keep that in mind, we can come to that later. So about the project, as I said, we're trying to apply Richard's approach and his team approach to Switzerland. So study indicators that could shed light on equity issue in the country. And we have three aims. The first aim is to select a set of relevant indicators. And we use the pragmatic approach with the Federal Office of Public Health, who are funding this study, is to start to focus on administrative hospital data. So easily available, high quality data, StatMed, that's what we start to work with. And the second part of the study is trying to apply what Richard presented. So look at association between hospital-based indicators and some measure of, I would say, deprivation or socioeconomic status. And then the last part of the study, which will take part at the end of the year and next year, is to try to understand what we observe in the data. Could be a quantitative approach if we can have enough variability in the data, or could be qualitative, so going to some places to try to better understand what happens in these places. The team, I'm working with Patrick Bodelman on the study. We have several researchers involved, currently involved in data analysis and also the systematic review, Karine Moschetti, Jacques Picher, Kevin Morizot, and Giulietta Luta. And we also have the chance to have several people in our institute that have experience in indicators and understanding how indicators can inform our understanding of the system. So Professor Petro Monbrivo, who is here, Maria-Nick Lepogam, and Yves Egli, who will help us also to go a little bit further in terms of choosing indicators that make sense for the study. And of course, Richard and Alex that are here, that you will hear also later, Alexander Green, are advising us on this study. So the first step was to select indicators, actually. So the constraint we have, the two main constraints, we focus on administrative health hospital data. So we're limited to that at the moment. And we need sufficient frequency, volume, to show some variability in the data. So that's the constraint we're working with. And then we are still doing some kind of feedback selection process based on the systematic review that we're doing, also expert consultation and discussion with the Federal Office of Public Health. And this is, I just wanted to show you some kind of a framework that we've developed here, not developed, but that helps us understand what we're looking at. So at the center, you have the hospital, and you can have, and many studies have used hospital-based indicators, really what happens during care at the hospital to relate that to equity. So that might be inappropriate procedures or low-value care, that could be patient safety events, that could be related to some socioeconomic status. So there are some studies looking at that. If you go on the right, you might have indicators that reflect more some part of the quality in hospital, like readmissions or repeat admissions, but also things that are related to continuity of care and the quality of the discharge after hospital. And what we're looking at, in particular as a first step, because there will be other steps, is on the left, as Richard described, indicators that captures or at least try to measure access and quality issues in pre-hospital ambulatory care and primary care. So there are different options in the literature to do that. A&E visits could be one, could be very specific, for instance, stage at cancer diagnosis that could reflect the quality in some sense of primary care. And then what we were using in these results that I will show you later are these potentially avoidable admissions. And I say potentially, of course, we can't avoid all of them. We don't really know if they are avoidable, but at least it's a good proxy for things that could be handled with better quality pre-hospital care. But this is just a very brief overview of what these ACSCs look like. You have chronic, acute version of them, and you derive them using the ICD-10 codes. It's just a technical thing here, but basically what you try to do is, what we try to do here is to use these indicators as a potential marker of equity issues. Of course, it's controversial. There are some debates about that, so we are going to try to refine these or look at other indicators. Again, as Richard said, we need to use more than one, but the preliminary results I show you today is with this indicator. Then we are focusing on aggregated data, so I have to raise that point. I know that there will be other Swiss researchers looking at patient level data, so we're not using patient level data. Yes, we start with patient level data with the hospital statistics, but then we derive these indicators at the Medstat region level. So we have 26 cantons in the country and about 700 Medstat region with between 3 to 10,000 population in this region. So you might have small cantons with only a few of these, handful of Medstat regions, but larger cantons like Bern with more than 50 Medstat regions. So that's our unit of analysis, so trying to derive these outcome or quality indicators at the hospital level in the Medstat region, and then try to get a measure of socioeconomic status, deprivation at the Medstat level. And that's also a challenge. We have aggregated data in this Medstat region on a range of variables, including demographic characteristics, income, occupation, housing-related issues, and so on. So that's the data we have. And then what we're trying to do is to make sense of this data, organize them, and put them in regards to the quality indicators. So we could do gradients taking each variable independently. It could be an income gradient in ACSC admissions, that might be an option. But what we are going towards is the calculation of an index. So we use some kind of dimension reduction approach to get an index that reflects deprivation in this region. There is one socioeconomic position index at the neighborhood level that has been developed. It's published in 2012. We might want to replicate that at a more aggregate level. I'm showing you here an ad hoc approach. So we used a set of variables that you can see at the top on education, employment, housing, and social support. And what we could do, I don't know if you might have idea later on, is do we need a new, an indicator that is similar to the IMD, the index of multiple deprivation that exists in England? Could we replicate that in Switzerland? Should we replicate that to get a better measure of deprivation at the local level? Open for discussion, of course. But so these are the two low-hanging fruit, I would say. So first use ACSCs, and then use kind of an ad hoc deprivation index just to show you what we find at this stage. And this is our map. These are just the rate of unplanned, so non-elective ACSC admissions per 1,000 population in the country. So you see there's quite a bit of variation across Medstadt region. And so you can start to try to understand what's going on here. It's very difficult. I have to say it's standardized by age and sex, and that's the only standardization we make at this stage. We follow also some advice here about that. And similar type of data, we can show it here. These are the cantons, and the graph shows you the within canton variation at the Medstadt level of these rate of admissions. So you can see that there's quite a bit of variation within cantons about the rate of admissions for this ACSC, ambulatory care sensitive condition, so potentially avoidable admissions. And now we put that, we look at the association between these type of admissions and our ad hoc index, and that's what you have, and that's similar to Richard's graphs. So you have this kind of proxy measure for socioeconomic deprivation. So it's kind of it's ranking, in fact, Medstadt by a proxy for socioeconomic deprivation. And then on the y-axis, you have these ACSC admissions. So you can see the national gradient. This is the average for the 4 years of data. We have data from 2014 to 2017. You have some sort of a gradient. But then what's interesting is to look at specific cantons. And I don't name the cantons because I don't want to blame at this stage the cantons. It's still ongoing work, so we don't want to rush to conclusion. It's just to show you what we are working with currently with our data. So these are 4 cantons, and what you have in the dotted lines is the national gradient, and the bold black lines are the cantonal level gradient. So we recalculate the gradient at the canton level. And if it's steeper, it means that there is more, a larger gradient, so potentially more inequalities within that canton, which is the case for this canton 4 at the bottom, for instance. Of course, there are issues with potential outliers. We have to be careful here, but just to show you what type of information we can get from this type of analysis. Another thing we discuss also with Richard is evolution over time. What happens in Switzerland, for instance, here with this gradient. So we can't see very well, but at the bottom you have the light blue line that reflects the gradient in 2014, and the dark blue line at the top, which reflects or shows the gradient in 2017. So there seems to be, and this is not fully statistically significant, but there seems to be a trend of an increasing gradient, so increasing inequalities over time, by means of using these indicators, of course. But that's what we observe, and we can do that again in the cantons. So the dashed line is 2014 for each of these cantons, and the bold line is 2017. So you might identify, if you trust this data, again, have to be careful, but if you trust this data, you might identify cantons where there's been a large increase in inequity, potential inequity issues. So in my flag you some regions or cantons where you want to do further work, and I think that's now the next steps of our study, is to see what to do with these. So first of all, of course, refine this approach. That's what we in the process of doing and want to do next. That's the next step. Think about other indicators that are potentially more appropriate, or capturing other things that are happening in the system, both regarding outcomes, so hospital-based indicators, but also regarding socioeconomic status. What should we do? Then, of course, I'm a quantitative researcher, so I would like to have nice multi-level models that put in relation supply-side factors, at the cantonal level, maybe regressivity of financing at the cantonal level, and put that in regards with hospital admissions and so on. Is it feasible? Do we have enough variation in the data to do that? It's an open question, and I think there is room here for qualitative investigation if we really identify a region where there's a lot of variation, potential issues with inequity with our indicators, with a set of indicators. Then we can have a case study or 2 case studies, try to interview people, understand what happens on the ground. And so these are open points. So we are really trying to understand the data we have, the limitations of that data, and that's one of the key issues in Switzerland. We have We don't have a lot of data on ambulatory care. That's a problem. But still, hospital episode statistics or StatMed is good, I would say. That's at least one thing we have. And I think that's what I wanted to cover today. Thanks very much.